First of all, I would like to thank Dr. Satyajit Sinha for including me in this instruction course of endophthalmitis. I have no financial disclosure to make. We have heard this saying long ago that prevention is better than cure. But when we talk in context of endophthalmitis, I think prevention is not better than cure. It is the best cure as far as endophthalmitis is concerned. Why? Because we all know the consequences of endophthalmitis, the morbidity it causes to the eye. We all know that it is one of the most feared complications of any intraocular surgery, particularly cataract surgery. The incidence has been reported varying from 0.05% to 0.1%. Once it occurs, it can lead to poor visual outcome, and if it is not controlled, then can it will lead to the loss of the eye. Since cataract surgery is the most commonly performed intraocular surgery, hence endophthalmitis is most commonly associated with cataract surgery. Although cataract surgery is the most frequently performed surgical procedure worldwide, there are insufficient data to suggest or to define the effective prophylactic measures to be taken, because it needs large number of patients to conduct such type of clinical trials. However, the prevention and elimination of the postoperative endophthalmitis is a constant goal of every ophthalmic surgeon. And with the appropriate pre, intra and postoperative prophylaxis, we can to large extent decrease the incidence of endophthalmitis. There was a study by Pethange and Associates. They reported that the common causes of endophthalmitis outbreaks, the most common being the contaminated solution 37%, with contaminated phacoemulsification between 22%, followed by ventilation system and defective sterilization, and many others. What are the sources of infection? In the study conducted by Spiegel and Bannerman, they have demonstrated that the genetic composition of the isolates, vitreous isolate obtained from the patients of the endophthalmitis, they were quite similar to the isolates present in the conjunctiva and lid margin. So most common cause of the endophthalmitis is patient's own flora. And second one is the contaminated surgical instruments, which can inoculate the microorganism, and the contaminated environment, or the OT, what we call. So what about the OT, which is the most important part of any cataract surgery? The operation theatre should be equipped with a standardized quality control system with separate clean and dirty circuits for all personnel and equipment or materials. That it should be having, as far as possible, the laminar flow with jointless floor by having the epoxy flooring, so that there is less chances of dirt or less chances of microorganisms settling on that. The walls should be, as far as possible, with antimicrobial paintings, so that there are less chances of environmental microorganism. Airflow system should be equipped with the HEPA filter, so that less and less number of microorganisms go inside the OT. They are all already filtered when the air goes inside. And it should be working under positive pressure, so that there is always less chances of air going inside the OT. So these things, as far as possible, should be taken care of. There are also risk of eye infection from bacterial flora of the surgical team. These are transferred via airborne route. So ideally there should be minimum of 20 air changes per hour in an operation theatre. And if there is laminar flow of air, then this has been proved that bacterial counts decreases within 20 seconds, within few seconds of the operating the air laminar flow. So this is one of the important things. If it can be done, it should be done. It has been found that most of the OT where we don't care for the air conditioning system, the majority of them showing the microorganisms. So this is one of the major culprits. So we want always service or take care of the air conditioning system. Needless to say that clinic procedure or clinic measures should always be taken before, during and after the surgical procedure of each and every day. Meticulous attention should be given to the OT. The instrument should be sterilized under strict monitoring, preferably through an indicator. And periodic sampling of the microbiological culture from OT table microscope should be done as far as possible. And we should keep the record of the batch number of the various materials used in the surgery. Pre-operative assessment or examination of patient is very important. We must look for any evidences of ocular adnexal infections like severe meibomian gland dysfunction, NLD obstruction, conjunctivitis, keratitis. This is the picture of meibomian gland dysfunction. Almost in 15 to 20% of my practice, I see some or the other form of MGD in patients. So these are very small things, but we often miss during the pre-operative examination. But any sign or possibility of systemic infection should also be ruled out when you are taking up the patient for cataract surgery. And this has been proved by Phillips and Tasman that the uncontrolled diabetes can be a major risk factor also for endophthalmitis, they have shown that in 21% patient, 21% of the patient who had endophthalmitis actually had this uncontrolled diabetes in their study. So diabetes is also a very important risk factor. We must not do contact investigations like biometry, syringing and Roplas on the day of surgery. Otherwise, whatever the microorganisms they are actually they get more exposed to infiltrate the eye. Intraoperatively, all antiseptic measures should be taken during surgery. In between two surgery, one should change the gloves. Sterile set of instruments should be used in every case, and phaco needle and slip should be changed as far as possible. This cannot be always emphasize the need of putting the ILSs away from the surgical area. This video will show how we can paste the steri drape and then put the ILSs away from the field of the operation. This has been proved by Smiths et al. That the cutting of ILSs and flushing of lacrimal drainage does not prevent or is not necessary before cataract surgery. So what is most important is to just keep away these ILSs away from the surgical area. Wound construction, clear corneal incision has been found to increase the chances of infection. So as far as possible, you should limbal or scleral incision. But when you are making corneal incision, ensure that the wound is properly made and it is watertight at the end of the procedure. Intraoperative complication, does it make any difference in the incidence of endophthalmitis? Yes. There are various reports which suggest that if there is any intraocular risk or complications, the risk of endophthalmitis is increased significantly. In a study by Wong et al., the risk of acute endophthalmitis increased by 8 to 11 times in patients who developed PCR during the surgery. By a study, Javid et al., they have shown that the risk of endophthalmitis was 4 times in patients who underwent cataract surgery with anterior vitrectomy versus those without any anterior vitrectomy needed. So, if you have PCR, you should always consider it is a very high risk case and to plan your treatment according to that. This has also been recommended that even you are doing a topical surgery nowadays, it is recommended that you patch the eye so that there are less chances of any sucking of any microorganism or fluid from the pulsations inside the eye. What are the various techniques by which we can prevent the postoperative endophthalmitis? Basically, what we have been talking the preoperative care in form of operation theatres and the patient hygiene. But when we come to the various antibiotics used, we can limit the organism by entering the eye by decreasing the microorganism on the ocular surface. We can prevent the intraocular bacterial contamination, or by doing the postoperative bacterial contamination with watertight wound closure. One should try to irrigate the organism entering the eye. Does preoperative antibiotic have any role? There is no clinical trial which can prove that it has definite role in preventing the microorganism going inside the eye or preventing the postoperative endophthalmitis. But there are several studies which provide some surrogate evidence to support that it has some role. So even if you are in doubt, always try to use some 4th generation fluoroquinolone because it is very broad spectrum and it penetrates into the anterior chamber also, so it provides fair good amount of prophylaxis in endophthalmitis. Does frequency or does it matter if you start 3 days before or 1 day before? One study quotes that it does not make any difference if you start 3 days versus 1 day. So even if you start 1 day before the surgery, then it is fair enough. If you add it on the providone iodine, if you add any antibiotic, it does not significantly further add on to decreasing the microorganism load. So if you are using providone iodine, which has to be used, there is no doubt about it. If you are using providone iodine, even if you miss operative antibiotic, there is no worry because it can work as well. There are some people who suggest that if you use indiscriminately this preoperative antibiotic, that can reduce the bacterial resistance also. One thing which is sure to be used or very important to use in preventing the postoperative endophthalmitis is use of providone iodine. That can be used for skin preparation 5 to 10%, or for conjunctival, you put it in the conjunctival cul-de-sac or 5% concentration at least 3 minutes before. It is so effective that it can kill the bacteria in 30 seconds. there are various studies which suggest that it can decrease the risk of endophthalmitis by 75%. So it is very, very useful, and it decreases the microorganism present in the adnexal area to a very significant level. And in recent review, 88 publication on endophthalmitis suggests that use of povidone iodine during pre-surgical antisepsis is the most strongly supported by all the observers in preventing the infection of the eye. So one cannot do away with the use of povidone iodine, and try to keep it pasted on the eyelids at least for 3 minutes. Does adding antibiotic in the intraocular fusion make any difference? There are some studies which suggest that it can be useful, but there are other studies to just to oppose this. Few studies say that like vancomycin, if you inject it in the solution, it can decrease the endophthalmitis, but again the chances that it can cause problem also. There are some studies which indicate that vancomycin can cause the cystoid macular edema. Moreover, the short-term exposure to antibiotics in the intraocular contents while we are irrigating the AC is so small that it cannot be effective in decreasing the load of the microorganism inside the eye. And there can be some dilutional error also as of now, so there is no clear-cut evidence to suggest that we should use any antibiotic in intraocular infusion. There are various studies which discourage, in fact, using infusion with antibiotics during the surgery. So this means of prophylaxis is not recommended. What about using antibiotics in the anterior chamber? I'm sure that most of you must be interested in knowing this. There was one landmark study which was randomized prospective placebo-controlled study in Europe in nine countries in about 16,000 patients who underwent cataract surgery. They were given intracameral ceftriaxone in one series of patients. In one group of patients, 0.1 ml at the end of the surgery before just hydrating the wound. Before hydrating the wound, one of the series of the patient received ceftriaxone, another no ceftriaxone, another ceftriaxone with levofloxacin, and another series group of patient only levofloxacin. And what they found that it decreased the risk of endophthalmitis about 5 times in patient who received this ceftriaxone. So this was an important study which was published in 2007, which actually gave some guideline that if you use some intracameral antibiotic, it would definitely decrease the risk of infection. But there are some people, or there are some opposition to this study also, like the endophthalmitis to start with, the incidence was quite high, which is actually not acceptable. Another thing is that when they use this antibiotic, why not use such an antibiotic which is broad spectrum like moxifloxacin? So there are various studies on moxifloxacin also, and it has also been proven that it can be quite effective as opposed to the ceftriaxone. It is much more effective in the way that it is a broader spectrum, and also there are less chances of TAS. And it is very easy to introduce inside the eye, because in ceftriaxone you need to reconstitute during the surgery. I just want to briefly add our results which we conducted in our hospital between 2009 to August 2012. We studied in 1,000 patients of each group, one group receiving no antibiotic. This was a retrospective study, in fact. One group of patients were injected ceftriaxone at the end of the study, at the end of the surgery, and another group moxifloxacin. What we could see that in patients where no antibiotics were given, 5% developed endophthalmitis. In ceftriaxone group, 1 patient developed endophthalmitis, that was fungal, and in moxifloxacin we did not find any case of endophthalmitis. This post-operative will be dealt by another speaker. So, just to summarize, proper sterilization and strict aseptic environment, there is no substitute to that. Pre-operative antibiotic, you must use 4-fluoroquinolone, and 5% povidone iodine is a must for any form of intraocular surgery. And as of now, there is no evidence to support that antibiotic in infusion can be any role. But intracameral antibiotic, there are several studies or many people they are using nowadays. So in my personal opinion, I think that it can be used. And if you take all these precautions, all these measures, I am sure that after cataract you can also have a relaxed situation like this. Thank you so much.
Thank you.